So good morning, happy Friday. I just had a couple quick announcements before we get started. The first is our monthly meeting for June is next Friday, June 16th from 11 to 1. And excited about that meeting. We're going to kick it off with a fun and interactive exercise playing the Hello game. That is a conversation game centered around advanced care planning. So please make sure to join us for that. And outside of that, please just introduce yourself in the chat and share any questions that you have along the way. And with that, I'm going to pass it over to Heather because we are so excited to have Dr. Stephen Nordstrom with us this morning.
Thank you so much. Welcome. We will be a small but mighty group, and I know folks are really excited about this topic, so we're excited to have the recording. I am in complete denial that our fantastic intern this spring for the North Carolina Serious Illness Coalition, Dr. Stephen Nordstrom, we really hit the jackpot with 5 amazing interns, and was really, Steve, you were an amazing connection with the group and did such fabulous work. And so this presentation and this talk is a culmination of your work. So I will quickly say, welcome, Dr. Stephen Nordstrom. You have been an amazing North Carolina Serious Illness Coalition graduate student intern. I giggle a little bit when I use the word student. You are quite the advanced professional. You are a physician. You are a base surgeon with the Canadian military and a bit of an overachiever besides all of your fabulous service to the Canadian people. You are continuing on with your graduate work, and it's just so impressive. So I'd love to turn it over to you. Before you dive into your work, really looking into how our providers can be better educated to have serious illness conversations, tell a little bit about you and what brought your fabulousness to our coalition.
Yeah, absolutely. Thanks for having me. So I'll start by introducing myself. So you've kind of mentioned the most important parts about me. I am an intern with the as an MPH student with the Gilling School of Public Health at UNC, and had this wonderful opportunity to come do my practicum work with you. So I'm a physician in Canada, kind of right in central Manitoba. In Manitoba, we don't have any fires here. Those are to the east and west of us. Although we do have a military response going to fight some of those fires. My day job is the base surgeon at a Canadian Forces base. It's an Army base. We have an infantry unit and an artillery unit here, as well as all the base support personnel. We do get helicopters coming up from Minot as well, and training in our training area, so we get to support them while they do some of their drills. On the weekends, I work on emergency covering rural communities, and I also do some of their inpatient and long-term care facilities. So my work with the North Carolina Serious Illness Coalition was to conduct an environmental scan on the state of healthcare provider education on end-of-life communication. It's something that has always been a struggle for us as physicians and healthcare providers. We don't have a strong comfort level in having advanced care planning and goals of care conversations. And I was a little bit surprised as I was going through the literature, and it took me in a direction that I didn't think I would be going at first. I thought I would be focusing more on continuing medical education and that period after school, but really much of the literature identifies that the biggest issue is how we train ourselves throughout the medical education period. And that's not to say that it's not opportunities after medical education, but it's really what I tended to focus on. So I did bring some slides, which I'll present. I don't really need to stick to them. So if we want to have a discussion instead, that's perfectly fine. You know, feel free to interrupt and ask questions, and we can talk around them instead of at them. So the slides are really geared towards medical education, but I did throw in some other stuff to include the postgraduate and continuing medical education as well. So let me see if I can share my screen here.
Great, you'll pull them up. And what I will share with the group, Steve is giving a condensed talk he joined and was so helpful with our North Carolina Serious Illness Coalition's initiative. And I think Ellie is on. There was a whole meeting looking at our medical schools in North Carolina, and we're calling it the Medical School Consortium. And Steve did a really thorough presentation, and this is a condensed version to share with you all. So really looking to take this information on how we can use it to motivate more action in our state of North Carolina. So this is a thank you to Steve. This is an encore presentation for our group, but this has already been shared with a lot of the medical school power players, if you will, or participants in our state.
And we'll
So
make it a
take
little bit
away.
shorter as well, too.
And we did want this to be both a presentation as well as sharing. So I will monitor the chat. So if there are questions, I will be my rude self and interrupt Steve or any of you can.
Wonderful. I appreciate that. So we'll get started with the slides here. So the objectives of this presentation or this talk is to go over a brief background, what the current strategies are, some of the outcomes associated with how we currently educate our healthcare providers in end-of-life conversation skills. Just to briefly touching on the evidence, that would be a conversation on its own to go through the evidence that's out there right now. And most importantly, the recommendations that I'm making based on what I was able to gather. So advanced care planning, theoretically it's beneficial, but historically it's been ineffective. So the basis of all this is a 2008 report to Congress on advanced directives and advanced care planning reported that, and I quote, although advanced directives and advanced care planning can be important tools to assist those facing end of life, the evidence suggests that end of life decision making in the United States is often poorly implemented, end quote. Advanced care planning and goals of care conversations really involve developing a deep understanding of a patient's values and beliefs, exploring what's most important to them to ensure alignment of their care they receive and the care they wish for. Engaging patients and their caregivers regarding end-of-life care can be facilitated through a broad spectrum of strategies, but healthcare providers are optimally positioned to initiate these conversations, facilitate ongoing goals of care conversations, and educate on the normal dying process to help patients and their families navigate through serious illness. And this is supported in the 2008 report to Congress, where it states that, and I'll quote again here, advanced care planning and educational tools will aim the process toward the clinician-patient relationship where it belongs and can best inform care in a clinically relevant way, end quote. And I will add as well that primary care providers are particularly well placed, having developed strong therapeutic relationships with their patients, especially those who are aging and seriously ill. And we'll touch on later that most medical education on end-of-life care and end-of-life conversations happen in the inpatient setting, which I would argue is too late. So what is the problem? Unfortunately, these conversations frequently occur too late, and decisions need to be made without a full understanding of the patient's values and desires for their care. There are many studies that document provider-related factors that result in barriers to effective end-of-life conversations. In one study, oncologists reported barriers as being concerned of causing distress for a person, their personal discomfort with death and dying, their personal discomfort with their skills and knowledge related to these discussions, lack of experience discussing end-of-life issues, and lack of mentorship. And the study further reports that even though end-of-life issues are central to oncologists' work, it's well documented that they receive little training in this area. So if oncology, who are dealing with serious ill and end-of-life care issues, almost on a daily basis, receiving inadequate training, it lends itself to believe that all specialties, including primary care, healthcare providers, receive little to no education on end-of-life communication skills. In fact, clinicians report more barriers than patients do in initiating and having end-of-life care conversations. There is another study that reports that fact that there's more barriers from the clinician side than the patient side. And the authors of that study found that clinician factors were more common and strongly associated with whether end-of-life conversations even occurred. And the suggestion is that clinicians are an important target group for improving end-of-life conversations. So what's the goal? In order to have the greatest impact on improving the patient and family's experience during the dying process, it's imperative to improve healthcare provider communication skills on these topics so that they can happen early and in a manner which supports our patients, allowing them to die with dignity in a manner that aligns with their values and to improve the experience for families and caregivers. Currently, education in end-of-life care is extremely poor, leaving healthcare providers feeling unprepared and uncomfortable having these conversations. The result is that advanced care planning is often ineffective, and goals of care conversations are often uninformed, as they occur in many instances when the patient lacks the capacity to effectively engage. So, how do we currently teach end-of-life communication skills? I'm not going to go too much into this, but these are really the teaching modalities in which one can educate on communication skills. So you can do didactic lectures, small group discussions. Importantly, there's role playing and simulation. This gives the trainee the ability to practice. And most importantly, and this is what I think is lacking the most during the medical education period, is direct contact and mentorship. And I'll get into that in a couple minutes here. So there's 5 medical schools in North Carolina. They're all listed here. I did a review of how end-of-life communication and advanced care planning and goals of care conversations are taught throughout the 4-year medical education program. I did this based on a review of what's available online. I was also to engage with faculty members at now the majority of the schools and really go through exactly what sessions and how much time and what teaching modalities are devoted to end-of-life communication skills. So there was significant variability between the 5 medical schools and how they prioritize and deliver end-of-life care, but there's certainly a couple key themes or key points. Only one of the schools actually required the students to rotate through geriatrics, although all schools likely offer optional electives in geriatrics and palliative hospice care. And I'll just add that I did have a conversation with Wake Forest, I think it was yesterday, no, it was Wednesday, and they do have a 2-week mandatory clerkship period during 3rd or 4th year in palliative and hospice care, where they spend 1 week in palliative and 1 week in geriatrics.
What school has the rotation through geriatrics?
Sorry?
What school has the rotation through geriatrics?
It's Campbell University.
Okay, great.
Yeah.
Thanks.
So there's also a lack of emphasis on developing end-of-life communication skills that likely contribute to physicians upon graduating feeling unprepared and uncomfortable in initiating end-of-life conversations. None of the 5 schools provide emphasis on early goals of care conversations in the outpatient setting with their primary care providers, and all are educated in the inpatient setting, typically during geriatrics or palliative care or hospice rotation. There also tends to be more of a focus on how providers deliver bad news and not so much on patient-centered goals of care conversations after the fact. My findings on a review of the curriculum correlate with the literature that there's really a lack of adequate training on end-of-life communication skills during the medical education period. And one study specifically stated that the data suggests more attention can and should be paid to education on end-of-life care in the medical curriculum so that students are well prepared to provide adequate end-of-life care. I did do up a slide here as well on how end-of-life communication could be taught after the medical education period, so during postgraduate and as part of continuing medical education. I don't want to spend too much time on this because it'll take up most of our time as well. And then I just listed off a couple examples of resources that are available. This is just a small sample size, but one examples where I was actually able to participate or get a detailed idea of exactly what is incorporated. Vital Talk and Ariadne Labs, they actually play a little bit more into my recommendations as well. Both those organizations provide very effective end-of-life communication skills programs. And there are actually ongoing, I don't want to say studies, but programs, one in South Carolina and one at ECU, that makes use of these programs in training their healthcare providers and medical students on end-of-life communication skills. So it's not to say that they're the end-all and be-all, but they're examples of effective programs that do work, but there is still room to develop new programs that work for an institution if they're not interested in either what Vital Talk or Ariande Labs has to offer, or want to make something a little more tailored to their realities. So what are the outcomes due to these gaps in medical education? It's evident that end-of-life communication is not prioritized in medical education, resulting in physicians starting independent practice who lack experience and have a low comfort level having these conversations. There's substantive evidence that demonstrates healthcare providers feel unprepared and hesitant to engage in goals of care conversations for multiple reasons, including lack of training, personal anxiety, and time constraints. There's actually more than 25 years of consistent literature reporting on the inadequacy of clinician education. Physician barriers are more common than patient barriers to end-of-life communication, with many physicians stating they feel inadequate in managing the emotional and behavioral reactions of patients. Yet despite the evidence and mandates to improve education, there's been no effective remediation. Physician attitudes appear to be a significant factor on whether end-of-life conversations even occur. The literature reports clinician-related barriers to communication regarding serious illness is consistent, and the most common themes are deficits in knowledge, skills and attitudes, challenges in prognosis, and difficulty initiating the conversations. The most important factor throughout the literature in leading these conversations is a lack of effective training. Serious illness communication training in U.S. medical schools is rare. There are barriers to reforming curriculum, such as institutional demands, lack of resources, and accreditation requirements. And I noted earlier in our North Carolina schools, training in end-of-life communication is sporadic and typically elective. Now, there are a few schools that do offer longitudinal programs, and they do a good job of it, and there are good results coming out of those studies where the schools have implemented a longitudinal program. But the reality is that most medical students learn serious illness communication skills on the fly by observation, lacking any constructive feedback or mentorship. And something else I will note about how the North Carolina medical schools educate on end-of-life communication skills is that it's not a mandated skill that they are meant to take part in. So when I look through all the checklists of required skills during clerkship, end-of-life communication is typically an observed skill only during one clerkship rotation. There's no actual requirement to participate in any conversation or lead any conversation. And there's no requirement for mentorship or feedback from preceptors. So this likely contributes to students coming out of school having no comfort level initiating end-of-life conversations. So further to the effect on clinician attitudes, lack of this effective training results in clinician hesitancy to engage in these conversations because they are unsure of the accuracy of prognosis. Most patients want to discuss the prognosis, but many physicians hesitate due to their fear of inaccuracy and the resultant expected harm from the patient. So when the prognosis is discussed, the physician tends to be overly optimistic and frame estimates favorably. The result is that patients making the decision that making their decisions are influenced by inaccurate information, and the decisions don't necessarily align with their values. One study in particular demonstrated that patients with cancer who believed they're likely to live at least 6 months made decisions in favor of more interventions and life-sustaining care, whereas patients who thought there was at least just a 10% chance of dying within the next 6 months favored more comfort measures. So I've gone over this actually in quite a bit of detail already, so I'm not going to go over this in detail again, but I will focus on the cost associated with end-of-life conversations. And I'm just looking at my data here, but there's a real cost associated with end-of-life conversations as well. And I do have one study that reported a much lower aggregate cost of healthcare for those who engaged in early end-of-life conversations. And it was between 30 and 40% lower costs in those who engaged in goals of care conversations and opted for less life-sustaining care. So just being respectful of time here, I'm going to get into some of the evidence, and I really just focused most of this evidence on the medical education period, although my environmental scan does include some postgraduate and continued medical education evidence as well. But really two studies that I wanted to focus on. So there's a 2017 study that implemented end-of-life conversation skills training during the surgical clerkship of a third-year medical school program. And what they found is that the students claimed, almost half the students claimed retention of communication skills at 24 and 48 months out after the training, and all thought it was valuable, with the majority of them also stating that there should be more opportunities throughout the medical education period to learn and practice end-of-life communication skills. And the Yale School of Medicine did implement a 4-year longitudinal end-of-life care program. So starting in first year and progressing through until graduation. And they found both subjective and objective improvements in end-of-life communication skills in graduate medical students. So they self-reported a higher comfort level with initiating and having end-of-life conversations. And objectively, they developed an OSCE in order to test this competency. The Medical University of South Carolina and ECU are the two programs I mentioned using VitalTalk and Ariadne Labs. And I don't think the South Carolina program has released any data. I know Wilma Rice was here maybe a month or two ago talking about that, and I'm quite interested. I'm going to follow up on this to see the results coming out. But subjectively or based on what Wilma says, it's quite positive at this point. I also just wanted to touch on emerging technologies, and I hesitate to call them emerging technologies, but I think these technologies could really be developed to help us teach end-of-life communication skills to not just medical students, but to improve access to practicing healthcare providers, to make it easier for them to engage in end-of-life communication skills. So unfortunately, the lack of education or effective education creates this cycle where we have preceptors that are uncomfortable having end-of-life communication skills. So there's a lack of mentorship for the students as they go through the medical education period. So how do we break that cycle? We need to teach those practicing providers to be more comfortable in having end-of-life conversations. It's difficult to get practicing providers out of their practice to conduct education, especially in communication skills where really we need to be practicing and simulating having these conversations. So this is where virtual reality or artificial intelligence can play an important role. Virtual reality has been developed for medical education. Maybe it was a year ago, had the opportunity to test out code training. So it was a team of healthcare providers that essentially ran codes, so cardiopulmonary resuscitation in a virtual environment, and they had like this little virtual trauma base set up, and you can grab your equipment and do things. Really, in practice, I don't think it was very useful, except for team communication. I found it extremely useful in that regard. So it's something that could be directly applied to end-of-life communication and a technology where you don't even need to get out of your office or out of your house to practice having end-of-life communication or conversations. Artificial intelligence is also very interesting. So there are these patient care models or patient models that have been developed based off thousands of personalities, and they can be quite responsive, and they can provide feedback and mentorship to the person having a conversation with them. So artificial intelligence is another emerging technology that I think can really play an important role in teaching end-of-life communication skills and make it much more accessible to those who maybe there's some significant barriers in terms of them participating in this type of training. So at the end of the day, medicine tends to prioritize quantity of life over quality of life. This doesn't really align with the values of many of the patients that we see, and results in healthcare providers that are not adept at initiating end-of-life conversations. Physicians and students often report they feel unprepared or uncomfortable with initiating end-of-life conversations with patients and their families, and the data demonstrates that students are less comfortable than experienced physicians in withdrawing life-sustaining care. While this aligns with the goals and values of some of our patients, it really doesn't for many. More emphasis needs to be placed on understanding our patients' values and having conversations about what the goals of care are for those who are seriously ill. Do they value quality or quantity of life? And what is quality to them? Do they have a specific goal, such as attending a milestone birthday, an anniversary, or a wedding? And do they understand the serious potential for adverse effects and harm associated with life-sustaining care? Medical education focuses heavily on treating disease and not so much on meeting the patient's goals. While there does seem to be a bit of a trend towards a more patient-centered approach, end-of-life care still seems to be a topic that is almost taboo. And this results in an underinvestment in this area during medical education and during the postgraduate period. Our patients and their loved ones are the ones that suffer the effects of this lack of training when they receive medical care that is not conducive with their goals, or decision makers are forced to make critical decisions on behalf of their loved ones, often resulting in conflict with other family members. The lack of direct exposure and mentorship during medical education tends to stigmatize end-of-life conversations, whereas we need to normalize these conversations given it is an aspect of life that's as common as birth. Everyone deserves to age and eventually die with dignity. It is not something to be afraid of, and healthcare providers need to be comfortable with facilitating the dying process. While patients and their families bear most of the burden of ineffective end-of-life communication, lack of training also contributes to negative outcomes in the healthcare provider's experience. And I had a story I was going to tell, but I think I've only got 4 minutes left, so I'm going to postpone that. This slide is important, and I wanted to talk around this slide, but in the last 5 minutes, I'm just going to focus on the recommendations. So the fact that there is no requirement to lead conversations during medical education does not set the conditions for success in our young healthcare providers. This training can be done either during clerkship or residency, but ideally it's reinforced throughout the entire curriculum starting in the first year. The biggest barrier for healthcare providers in facilitating end-of-life conversations is simply a lack of comfort because they don't have these conversations while they have mentorship and backup during their medical education period. So based on the available evidence and the gaps that I noted in a scan of the current strategies and how we teach end-of-life communication skills, I've made a list of recommendations for medical education that would support improved end-of-life care for seriously ill patients. The first is initiate training early in the medical education period on end-of-life communication skills, and this is in the first year. Second is to develop longitudinal programs that build on training year after year. This is the only way in which to train physicians who are comfortable to initiate and facilitate effective end-of-life conversations once they enter their independent practice. Third, training programs need to involve simulation through role play with or without the use of standardized patients. Communication skills cannot be sufficiently taught through didactic means, as it's a skill that requires practice and feedback. Fourth, develop training programs that are reinforced with opportunities to observe preceptors or residents leading end-of-life discussions and require students to participate in these discussions, and also require feedback and mentorship from their preceptors. Fifth, change how we teach end-of-life communication to ensure a mindset that end-of-life communication is an intervention that needs to be taught, learned, and practiced to maintain competency. Medical training programs need to focus on developing communication skills and facilitating discussions about the normal dying process, involving surrogate decision makers and empowering patients to have ongoing discussions regarding their values and goals at the end of life. So as I stated, there's existing programs that can be incorporated, such as VitalTalk or Ariandi Labs, but new programs can also be developed. We just need to evolve the philosophy on communication at end of life. Sixth, medical education needs to ensure end-of-life communication skills are instructed in multiple settings, not just the inpatient setting. This is because the outpatient setting is the optimal environment to start having these conversations with the patient's regular healthcare provider who they've developed a therapeutic relationship with. Seventh, it's difficult to initiate change when the historical barriers remain, so facilities need to identify the ongoing barriers to implementing these longitudinal end-of-life care programs. And finally, incentives need to be developed to motivate clinicians to invest time and resources into participating in end-of-life communications, CME, as well as implementing this intervention into their practice. This could include professional credits, assistance in creating the time needed for this training, and monetary remuneration. So I also have a slide here on recommendations for further study, but it is 8 o'clock, so I will stop talking now. I'm certainly here for any questions, or if you've
Great.
got any feedback or points.
Thank you. And as you can tell, since Steve is on the western part of Canada, it's 8 o'clock for him. It's 9 o'clock for us. I see that there's a question. Mary had a question, and Heather has a question.
Yeah, thank you. This has been very interesting and great work. So thinking about teachable moments for physicians, with doctors focused on curing folks and making them better, and being so overwhelmed by everything they've got going on in medical school. But what about continuing education after they get out? I mean, to me, like teachable moments after they've actually had a lot of exposure to this type of thing, that if more opportunities were made available for doctors to take advantage of things after they are actually out in the real world doing their practices and things like that, when they've actually had to experience it. So just a thought, and I'm sure you probably thought of that also.
Yeah, absolutely. And I touched on that in the paper that I wrote. Like I said, this is kind of more geared towards the medical education period, but I agree that's a very important time. And it's not just important in training those who maybe have a lack of comfort right now, but also reinforcing the skills that they learn over the course of their career. So there are programs available, and I went through a number of them. I actually participated in a few of the CME and got myself some CME credits. I do find, though, that a lot of the internet-based CME on end-of-life communication just isn't responsive and not very good, which is why I think things like virtual reality or artificial intelligence can play an important role in the future. The best way to train on end-of-life communication skills is really just to practice, and that can be through role player simulation with standardized patients. But then you run into all these barriers where it's hard to get a practicing physician out of the office for a day or 2 days, and potentially even have to travel to do this. So that brings me, and this wasn't on my original presentation, but I added it for this group, that 8th bullet about adding incentives for practicing providers to make it more likely and help reduce those barriers of them engaging in CME.
And I'll make a quick comment, which is also a way to highlight the fact that Steve has put together just a really intensive paper that has all of this information. He, as I said, as we've talked about it privately, he's giving us all this information in a box with a bow on it. So I've had the pleasure, I think it's like 23 or 24 pages, which we can use and create some. And I think Steve is well positioned to have one, if not more, publishable articles from his research. So I get to highlight that there'll be a paper coming in different executive summaries. Having read one of the first drafts of it, what was interesting was the research, Steve, if I say it correctly, that research has shown that more effective communication, while I was thinking more about continuing medical education, CMEs, all that the research is showing that the best time to do it is in medical school. So that was fascinating. And so that really worked with. So I think there's a both and in terms of the whole trajectory of physician training time, continuing before and after school. But I thought that was fascinating. The research really points out that the most effective time is get them young and early.
Absolutely.
Heather,
and that's not the only time too, because unfortunately, and I was talking with somebody from Wake Forest earlier this week, it really creates a cycle though. So we do need to engage practicing healthcare providers. Otherwise, when they're mentoring medical students or residents, they're not going to be effective mentors in end-of-life communication. So it really is two audiences that we need to tackle to end this cycle.
And Heather Burkhart, you had a question. It'll be our last question, I think.
One off, but this was great information, and I'm excited to see all the work that you've done sort of behind it that Heather was talking about. But I'm kind of curious, in your scan and research, you talk about, physicians their level of comfort and about talking about these issues, and, they avoid them. I'm just curious if you ran across anything on the patient side to see if patients really are upset or uncomfortable talking about these end of life conversation. I mean, my gut tells me they're probably not, but I just wonder if there's anything on the patient side that talks about how they engage in these conversations or feel about them.
So there certainly are some patient barriers, but they're typically not what actually prevents these conversations from happening. And a lot of the perceived barriers that we have as healthcare providers don't actually show up in the literature as being true. So there's a study on one of the concerns from healthcare voiced by healthcare providers is causing emotional distress in patients and their loved ones in initiating and having end-of-life conversations. But what the literature said is those who have early end-of-life conversations wind up having better quality of life and decreased mental health diagnoses in their caregivers after death. Those who don't engage in end-of-life conversations have a higher prevalence of mental health diagnosis such as MDD and PTSD in caregivers after death, and a worse quality of life in the week before death. So a lot of the perceived barriers, patient barriers, don't actually show up in the literature, and it winds up being the opposite.
This is Ellie, and I wanted to just add in really, really quickly that there at ECU Health, we're not only providing this education for our medical students and interns, residents, and fellows, but we also have courses that we offer free for our medical providers, and they earn 7.5 hours of continuing medical education to participate in them. And we have a struggle getting people to come to them. And I think part of that is, once a clinician is out in practice, there's sort of this psychological barrier, like they feel like they should be good at this. They don't want to risk, sort of exposing themselves as not good at this. And so they tend to opt out of this training. So, the feedback that we're getting from our students is, they feel like the medical education piece when they're in medical school is an ideal time to get this training done.
Well, thank you. I hate to wrap up this conversation, but we're a little past time, and clearly we are all engaged. And really, Steve, we cannot thank you enough for this. We cannot thank you enough for your previous presentation. And I know there's a draft for me to read in my inbox right now. And so all of this information with a lot more detail he has presented. And at some point today, I will fill out your evaluation for your practicum, your internship. You will get exceed expectation is the highest rating. So I'll tell you now, that's what you're getting. Really, you've got others here from the coalition. We cannot thank you enough for all of this wonderful work that I really think will give us great information and data and recommendations and themes and all of that to move forward with our work this year and next. But really, I know my intense gratitude, and I'm sure with everyone that's looking at you right now. Thank you so much.
No, thank you. It was a pleasure working with everybody and all the fantastic people I got to engage with over the 6 months. I mean, I'm always around if anybody wants to just talk about this or anything else. I like to talk, and I've always got an opinion on things. But no, really, this was eye-opening, and I got to learn a lot during this as well. It was wonderful.
Well, great. And we hope to all meet you in person, since there's a nice coalition of us that are trying to, when you're all done, and you're ready to come to the States, we're all ready to recruit you to be a physician here in North Carolina. We know you have your heart set on a few other states when you leave Canada, but we want you here, and really, thank you.
Pleasure. Thank you very much.